what are the screening methods that we can do so that we can catch these heart diseases early?
You can start at the age of 20 to 25. Otherwise, without any risk factors, you can start around 30 years of age.
So what is the impact of exercise on heart health? How
Yes.
long should the exercise be?
Exercise generally, as per our cardiology perspective, we say minimum of 150 minutes a week.
Okay, so what heart rate should you reach when you are doing cardio exercises? Why is heart disease increasing in women? Tell us about the impact of diabetes on heart health.
Diabetes is a silent killer. Diabetes is the disease which can affect any organ in the body.
What is the role of yoga, meditation, and its effect on the heart?
They have a very, very protective role. See, nowadays it is not only the physical health, it is also mental health also is very important.
If I ask you what are the best food items for heart health? How does alcohol impact the heart, and is there any safe limit?
Recent World Heart Federation 2022 data, there is no safe limit for alcohol.
What does stress do to the heart? Hi and welcome to Decoding Health with Dr. Aanchal. On this episode, we have Dr. Vijay, a cardiologist practicing in Bangalore. In this episode, we are going to discuss about what are the risk factors for cardiovascular diseases, what are the lifestyle changes that you can make to protect yourself from getting heart diseases. It is an in-depth conversation about all the risk factors and how you can improve your heart health. I'm sure you'll find it useful. Welcome, Dr. Vijay, to Decoding Health.
Thank you.
With this podcast, I want to educate people about heart diseases, what are the common risk factors and how they can avoid heart disease, how they can prevent it. So we'll discuss about lifestyle changes, dietary changes, what oils to use for cooking, common questions that people have.
Yeah.
Now we have seen that heart diseases are on the rise, so we will cover all this aspect.
Yes.
So let's start with why is there an increase in the number of heart diseases today?
Yeah. To start with, if you see every day in the television, especially in Karnataka, we can see a lot of young people below 40-45 years dying of heart attack. So this is all because of our own mistakes. So basically it is the lifestyle, demographic factors and environmental factors are responsible along with the family history. These are the main things which play a role in having a heart attack in young people. If you come to the lifestyle changes, everybody are more happy to have an unhealthy diet. So eating more processed foods, high fat diet, especially trans fats which contains lot of cheese, butter. These are called high trans fats because they are processed foods. Then sugary beverages, you can see a lot of people along with the normal food, they usually have the habit of having a soft drinks which contain nothing but a highly sugared foods. And these are the main things. Then sedentary lifestyle, everybody start working by sitting, nobody wants to do any physical activity, and increase screen time, addiction to the mobile, then increased tobacco, alcohol consumption, substance abuse, along with that rising diseases like obesity, diabetes, hypertension, then lack of sleep. This is one thing which we have to stress upon in this lecture. So, and genetic factors, definitely yes. So these are the factors. See, all these factors were there since many years. It's not that they are not there. All these factors, the amount or the incidence has increased over few years. That is the reason why the heart attacks are increasing in young population now.
So when we talk about heart diseases, we only think about heart attack. But what are the common heart diseases that you come across?
See, heart disease, when we say, it is not only the heart attack or myocardial infarction what we say. See, cardia includes the muscle, it includes the valves, also it includes the blood vessel. So all these three together we call it as cardiovascular system. So if the muscle is affected, we call it as myopathies. So it could be enlargement of the muscle leading to hypertrophic cardiomyopathy, or weakening leading to dilated cardiomyopathy, or heart rate rhythm, what we say heart rate related. So if there is increase or decrease can also lead to cardiac disease, we call it as arrhythmias. And then blood vessel related, one is coronary artery disease. If the same thing develops in the peripheral vessels other than away from the heart, we call it as peripheral artery disease.
So these are the
common things which we see in our practice.
So what according to you are three most major risk factors for heart disease? Of all the risk factors you've said, the most common and the most impactful?
See, most impactful over past few years is one is lifestyle, change in our lifestyle. Second thing, increase in the level of chronic diseases like obesity, diabetes, and hypertension. Third one is stress. This is the most important. These three factors which we have seen as increased over past decade.
So when we talk about risk factors, we talk about modifiable and non-modifiable risk
Non-modifiable.
factors. So a little bit on that, how much genetics impact heart diseases? If let's say one parent has suffered with a heart disease, what are the likelihood of the child developing it? And what are the modifiable risk factors?
See, if you see the risk factors, generally the reason why we divide also is modifiable are the things where we can change and reduce the risk of heart disease in us. Non-modifiable are which we can't prevent. So when you come to the modifiable, as I told, diet, definitely yes, we can change our eating habits. Then smoking, alcohol, definitely we can quit smoking, we can reduce or stop alcohol consumption. If there is acquired or without any familial hypercholesterolemia, definitely yes, we can reduce with medication and lifestyle changes. Overweight, definitely we can manage. If there is high sugars or blood pressure, definitely we can control. Non-modifiable, when you come, it is the age. When we see coronary artery disease, it increases exponentially with the age. As you age, the risk goes up. That is a non-modifiable risk. Then gender. So women after postmenopausal are more prone to develop heart disease. Then when you come to the race and few ethnicities, those few patients are few ethnicities or races are very prone to develop heart disease. If you see Western population and Indian population, Indians have 5 to 10 years earlier onset of coronary artery disease when compared to Western population. This is basically a genetic or race ethnic related issue.
Okay. Why is heart disease increasing in women?
Yes. So one is, as we know, it is all, we can say it is traditional risk factors, what I have told earlier, plus women's specific risk factors. If you see women's specific risk factors, one is increase in the rate of PCOS. PCOS, polycystic ovarian disease, or a syndrome. Then pregnancy related issues like eclampsia, preeclampsia, or gestational diabetes or gestational hypertension. Then postmenopausal. See, postmenopausal women are more prone to develop coronary artery disease, because during postmenopause the protective effect of the hormones, especially estrogen, is withdrawn. Thereby they are very susceptible to develop the coronary artery disease. And along with that, as we know, same like in men, they are like lifestyle, diabetes, hypertension, other all risk factors contribute for increase in the rise of coronary artery disease in women.
What are the role of oral contraceptive pills in thromboembolic diseases?
Yes. See, always oral contraceptive pills are thrombogenic. They increase the clotting capacity in the blood. So generally, whenever we get any patient with a thrombosis of pulmonary embolism or a deep vein thrombosis or anywhere else stroke in the body, one of the history we elicit from a woman is use of OC pills. These hormonal preparations increase the clotting capacity in the blood. And they are prone to develop clot anywhere in the body.
Okay. So what are the screening methods that we can do so that we can catch these heart diseases early? At what age should screening start, and what defines what age it should start, in the sense that, if you have genetic history, you should be screened at 20, 30, 40. How often should screening be done, and what are the usual screening tests?
See, this is actually, traditionally speaking, now most of the studies which say earlier, they used to, other than a National Heart and Lung Institute, which says that with a history of familial hypercholesterolemia, you can start screening around 11 to 12 years of age. Most of the other evidences suggest that you can start at the age of 20 to 25 if there is a family history of any heart disease or hypercholesterolemia or diabetes or hypertension. Otherwise, without any risk factors who are low risk, we can start around 30 years of age. So that is the ideal thing to start.
And how often should the screening be done?
Generally, if it is no risk factors at 30 years, you can do every 4 to 5 years once. And 40 to 49 years, you can do every 2 to 3 years once. 50 plus every 2 years. And after you cross 60, every year is better to get the screening test done. These all apply to a person who doesn't have any risk factors. If they have risk factors or if they are very prone to develop heart disease, then the screening should be very narrow. I mean, intervals should be very small.
Okay. So what are these tests that are done? I just want you to list them out.
Yeah. See, generally at the age of 20 or earlier, we generally say lipid profile. In that lipid profile, usually you should also look along with, see, if you see lipid profile, it doesn't mean that it is the total cholesterol alone. See, there are few laboratories which will do only total cholesterol and send as a package of many corporate checkups or any. So it is the split components of the lipid profile which is very important. So LDL, among the cholesterol, we have something called as good cholesterol, bad cholesterol and fats. Fats are nothing but triglycerides. Good cholesterol is HDL, high density lipoprotein, and bad cholesterol is low density lipoprotein. So all the three components. Along with that, now newly we also have apolipoproteins, especially lipoprotein A and apoprotein B are very important markers of coronary artery disease. So these things are must when you check the lipid profile. So along with that, sugars and electrocardiogram, ECG. So this is at the age of 20. And specifically if they have especially some cardiomyopathies, what we were speaking, muscle related disease, these are also responsible for sudden cardiac death. We can see many times patient who was working out in a gym or exercise suddenly dies of cardiac arrest. So one of the causes is hypertrophic cardiomyopathy, which probably doesn't produce any symptoms, so undiagnosed earlier. So these things, if there is strong family history, these are the in those cases we need to do echocardiogram, where we can see the structure of the heart, function of the heart, muscle thickness, those other important parameters can be seen. Otherwise, routinely this. Once you reach 30, sugars, cholesterol should be there. 40 plus, I feel ECG, echo, plus or minus treadmill, and cholesterol, sugars, those should be. And in specific category of patients, I would like to mention something called as CT coronary calcium score. So this is one thing which has come up in recent years. So we usually calculate or assess the risk of a person by using ASCVD score. It is a cardiac risk score we assess based upon the patient's family history, whether he is a smoker, is a cholesterols. So these parameters we take based on the risk score. If he belongs to intermediate risk category, we need to do CT coronary calcium score. See, many times why I am stressing so much about it is, we have seen a patient coming to my clinic or a hospital 1 week back, getting the treadmill. He used to walk very well for 10 minutes or 10 minutes, what we assess the function. ECG was normal, patient didn't had symptoms, and he has gone home. After a week, patient attendants or family people comes and says that, sir, patient had an heart attack. So these are some scenarios where, and they came and they asked me why the patient has an heart attack. 1 week back we have checked it. So the loophole of treadmill or a false, there is 10% false negativity about the treadmill, where slowly developing blocks may be missed on treadmill. So in those cases, especially when the family history is very strong, or person has risk factors like smoking, substance abuse, or a diabetic or hypertension, at least once he crosses 40 years, I would suggest at least to get one CT coronary calcium with or without angiogram.
Yeah, this is a very important point, because people feel that just getting the blood test is enough. But for cardiac diseases, for screening, there are very specific tests which can help in diagnosing it early.
Correct.
So now I want you to tell us about the impact of diabetes on heart health. How controlling sugar is important, and why high sugar, what are the changes that it occur, what are the changes that it makes in the vessels that makes you more predisposed to develop heart diseases.
See, diabetes is a silent killer. That is the tagline I can give for the diabetes. If you have diabetes, diabetes is the disease which can affect any organ in the body. It is not only the heart, not only the kidney, it can affect any organ including the blood vessel. See, diabetes can affect the heart at all the levels. As I told, it can affect the muscle, leading to diabetic cardiomyopathy, where heart pumping can be become weaker, and patient may go for heart failure. It can affect coronary arteries and can lead to heart attack. It can also affect the conducting system of the heart. or it can affect the other organs, and secondarily it can affect the heart. If there is the diabetes for a long run, if it affects the kidney, then it can lead to renal failure. Secondarily, it can affect the cardia, leading to heart failure, what we call it as cardio-renal syndrome. So diabetes and kidney disease are like a brother and sister. So diabetes, that is the one thing, and it affects by, as we see something called as, when we diagnose initially diabetes, person will be all right, you can't even say that he is a diabetic if you see from an outside, because many times you have initial phase, body has that resistance to control the diabetes. Initially without medications also, person can be happy for a few years, that is called as honeymoon phase in the diabetes. So but inside the body it will be causing the microvascular damage, which you will come to know, see only after over few years, where it is an irreparable damage. So it will cause the vessel wall injury, what is called as microvascular dysfunction. That is the base for formation of heart block or any block in the arteries, peripheral arteries or inside the heart vessels. Later on, over that injury, cholesterol starts depositing, then calcium starts depositing, forming a small round block like thing. It's like a pipe where gradually it starts narrowing inside the wall by deposition of fats, deposition of cholesterol. So gradually, once it reaches a critical stage, then the blood supply becomes hampered. So initially what will happen, heart has that capacity initially at rest, because heart need not work more when you are doing a normal walk. But when you are walking at a uphill, or when you walk little bit brisk, that time heart needs to spend more energy. That is when the blood, what is going through the block, will not be sufficient. Then patient starts developing chest pain or shortness of breath. This is called as effort angina, or a warning sign of heart attack.
So, in my clinic also, when I get tests done and then I find that the HbA1c is increased or the blood sugar levels, like the fasting blood sugar is increased, they tell me that no, but I've had it increase. Sometimes when I eat mango, it goes up. When I stop eating mangoes, it'll come down. So, they are not taking it seriously enough.
Correct.
But we know how important controlling diabetes is.
Correct.
Why is there so much of denial amongst people to acknowledge that they have diabetes and to take medications for it?
Yeah, this is one thing, because it will not affect immediately. It will not give them trouble immediately. See, people are really affected when it gives them immediate pain. So diabetes is the one, initially it will not give immediate pain. It is over a chronic period. See, especially diabetes, when you tell in relation to the heart, very important is diabetes. One is before development of heart blocks, it increases the risk of coronary artery disease. Once patient has already undergone a bypass surgery or a angioplasty with stent, then if the diabetes is not under control, the longevity will comes down. There the block stent gets blocked very early because of deposition and early development of thrombus inside the stent. So controlling diabetes is very important. If you have, see, suppose if you have two persons, one person, if you take two patients have undergone angioplasty, diabetic patients, in the same setting on the same day, single vessel, we can say, because if it is a multi vessel, then also outcome differs. Just for an example, so one person is having a good diabetic control with HbA1c of less than 7. So if you say 6.5 to 7 is a very good control for diabetes. Another person has very not a good control, around HbA1c of 8 or 9. If you follow both the patients over a span of 2 years, 3 years or 4 years, the onset of stent restenosis is less, or duration is longer in a patient who has diabetic control. Who has uncontrolled diabetes, they may develop within 2 years, 3 years, we have seen coming back with stent thrombosis or stent restenosis. So it is very important to control diabetes especially.
So please don't take it lightly.
Yes.
A lot of people feel that they refuse to acknowledge they have diabetes. They feel that if they go back to a certain diet, their sugar level will be controlled. But no, after a certain point, you will have to take it seriously, and you might have to take medications in order to improve it. Now I want to talk about another very important risk factor, which is hypertension, increased blood pressure, and how it impacts heart health.
See, normally blood pressure, it is nothing but a pressure exerted on the vessel wall. That is what we define it as blood pressure. So when the blood pressure increases, the pressure exerted on the wall goes on increasing, and the endothelium is the protective layer, as I told earlier. So when the pressure increases, it starts damaging everywhere. So once it damages, first thing is on the heart. When you come to the heart, so heart is nothing but initially it is a muscle. If the muscle is subjected for chronic pressure overload, now hypertension is nothing but pressure. So heart compensates it by enlarging the muscles and increasing the number of muscle fibers, what we call it as concentric LV hypertrophy on the echocardiogram. So this is initial phase where body adjusts. Later on, it once it's like an elastic band, it stretches to certain extent. Once it goes beyond, it starts weakening. So same way, heart muscle starts becoming weaker after certain point of time. So hypertension can cause heart failure. Hypertension can increase risk of coronary artery disease. Hypertension can increase risk of peripheral artery disease. Hypertension can increase risk of stroke. Hypertension can increase risk of renal dysfunction. So these are the main things on the cardiovascular system. So it can increase or accelerate the development of blockage in the heart vessels or in the abdominal aorta, I mean blood supply in the aorta, kidney vessels. If it increases in the brain vessels, especially carotids and mid cranial arteries, they may lead to stroke. Sometimes the blood pressure is very high, because lot of times we see people saying that I don't know, people are also reluctant to take English medication. This misconception is there in lot of people. So when we say they have more faith in an alternative medicine than an English medicine, if I say why you are not, sir, lot of side effects with the English medicine. See, thousand crores of people are taking antihypertensive medication over last so many years. All are time tested drugs. If you see, there is always a gradual improvement in our investigation, and newer drugs are coming out with for the hypertension or diabetes. Now there are diabetic drugs which are used without diabetes also in a cardiac patients, cardio-diabetic drugs. So many newer class of drugs have come with less side effects, and definitely these have known side effect profile. When they come for regular checkup with medications, we will definitely identify them, we can sort it out, and we can control the blood pressure. If they are reluctant or hesitant to take the medication, unnecessarily they develop all this stroke and renal failure, kidney problem, or heart attack or heart failure, and they will land with some other doctor.
So what is the level at which you feel it can be modifiable with lifestyle changes of blood pressure, and at what level medications are absolutely necessary? Let's say one time you've checked the person's blood pressure, when do you decide has to be on medication, or no, you want to follow up after lifestyle modification?
Yes. See, blood pressure, generally single reading measurement of blood pressure, we don't advise medication. We say minimum 3 blood pressure recording on 3 different occasions are required, and always make sure that whenever you check the blood pressure in an initial visit, both upper right and left upper limb should be checked. This is one thing which you have to take care. And initially when you are diagnosing hypertension, patient should come into a clinic, just stay for 10 minutes. He or she should not have a caffeine half an hour before the procedure, before checking the blood pressure. Then he has to enter your chamber sitting calmly on the chair, and his feet should be touching the ground and his hand should be rested on the arm. Then you need to check the blood pressure. This protocol has to be followed, and minimum of 3 readings on different occasion has to be checked. Generally, earlier there was some age discrimination saying that hypertension definition. Now, any age, it is more than 140/90 is considered as hypertension. And now recently a lot of studies are coming up even below 140/90. 130/90 we say that high normal blood pressure, just to increase the awareness among the people and also increase longevity and to prevent the secondary side effects. So still at increasing awareness, we say 130/90 also patients should start engulfing in the lifestyle changes.
So let's say the person has 140/90 on 3 different occasions. Do you then put them on antihypertensives or give them lifestyle modification for 3 to 6 months and then evaluate again?
Yes, this is actually a very important question, because even when a person comes to me, 30 years old, 40 years old, 140 by 90 on first or 3 readings, I would not suggest him the medications in the first. I would still suggest him for lifestyle changes. And if it goes beyond, if the initial blood pressure is more than 160 by 100, yes, I would start medications on 3 different occasions. Yes, 140 by 90, still I would ask him to do lifestyle changes, come back and meet me after 3 months, and if possible, monitor blood pressure in the home.
Yes, so it's 160 by 100.
Yes.
If you have more than 160 by 100, then medications have to be
First,
started.
yes.
Only modifying your lifestyle will not bring that kind of a change.
Correct.
Okay. And just a little bit on how safe these antihypertensives are, and any new antihypertensives that have other good impact on the body, because a lot of people, like you said, prefer to take alternative medicine,
Correct.
Ayurvedic, homeopathic medication, and just not take any antihypertensives because they are worried about side effects.
Correct. See, now we have, earlier we had 2-3 groups of antihypertensive medications. Now we have more than 8 to 10 group of medication. And these medicines are such a way that not only they control the blood pressure, these medications also be started based upon their risk factors associated. See, if a patient has hypertension and heart disease, we can start with something called as telmisartan, ACE or ARBs with beta blockers. Or now newer group has come as sacubitril valsartan, which is a miracle drug, especially in heart failure. Especially heart failure with lower ejection fraction, we have seen many patients completely normalizing the heart pumping. Then if patient has diabetes and hypertension, definitely this ACR ARBs not only control the blood pressure, they also control the kidney side effects of diabetes, especially preventing the microalbuminuria or nephropathy, delaying the, so these medications have definitely role with other things and other systems also.
This
And
is what I wanted to bring out, because a lot of people feel that the blood pressure medication is only impacting the blood pressure. No, it's actually protecting your kidneys also.
Correct.
This is very, very important to understand,
Yeah.
so that they are encouraged to take these medications under supervision, of course, and monitor all these parameters in order to get complete benefit.
Yes. In this situation, I would like to tell you one more thing. See, many times what happens, non-hypertensive having an heart attack, we prescribe beta blockers for the control of heart rate and ventricular remodeling after myocardial infarction. Once they go to the pharmacist, they say that why you are taking antihypertensive medication. Lot of patients came to me and asked, sir, you have prescribed me BP medications where I don't have BP. I mean, in a scenario, these are the other scenarios which we see also. See, these things have, I brought out this scenario to say that these antihypertensives have better effect not only for blood pressure control, other systemic effects also.
Yes. Now, another risk factor is obesity. How does obesity impact heart health, and why men having abdominal obesity is a major risk factor for developing heart disease?
See, obesity, the amount of, when we say obesity is BMI, we calculate basically scientifically based on body mass index more than 30. See, in obesity, the pressure on the heart or work on the heart will be more. Generally, it undergoes secondarily hypertrophy. Then a person may develop pulmonary hypertension secondary to obesity, which we call it as car pulmonale in our scientific medical term. So that will increase the risk of obstructive sleep apnea. That secondarily it will increase the risk of car pulmonale. And obesity, once it is also a state of chronic inflammation. So that is how it will lead to coronary artery disease, stroke, heart failure. And in men, as you told, abdominal obesity, we generally measure by waist hip ratio, which in men it is more than 0.9. We say it as abdominal obesity. It is always not the outside fat which is responsible for the disease. It is the metabolically active fat which is inside the organ which is responsible for heart disease or inflammation which is happening in the body. See, generally if the abdominal obesity is there, they will have more insulin resistance, because insulin acts on the fat cells. If number of fat cells are more, the resistance for the insulin will be more. Then they have more chances of developing diabetes, hypertension and other issues secondary to obesity. That is how they are more prone to develop heart diseases.
Yeah. So losing weight should be
Definitely,
the
yes.
most important change that you bring in your lifestyle.
Yes.
If you are suspecting heart disease or if you
Yeah.
have family history of heart disease. Another important risk factor is increased cholesterol. So what are the levels of cholesterol that you should look at, and how are these cholesterol lowering drugs effective, and their long term, if there's any side effect, how
Yeah.
long you have to take it, a little bit on that.
Yes, very important. See, cholesterol, as I told earlier, cholesterol composes of good cholesterol, bad, and fats. See, good cholesterol generally, which is called HDL, is most often lower in Indian population. And studies have shown that increasing the HDL by giving medicines is not going to help, does not help in any cardiovascular morbidity or mortality benefit. So HDL can be only increased by strict brisk exercise and weight loss. That is the first thing which we have to do. When you come to the LDL cholesterol, which is called bad cholesterol, responsible for all the events which happen. So generally, ideally it is better to keep it below 100 in a non-cardiac patient. So if a patient had a cardiac event in the past, like he had an heart attack or a stroke or anything, LDL ideally should be kept below 55. And triglycerides, when you come, triglycerides are nothing but a fat. It indicates indirectly your insulin resistance or activity. If you are sedentary, overweight, or secondarily in some cases like hypothyroidism or familial hypertriglyceridemia, those cases definitely yes, triglycerides, if it goes beyond 400 or 500, you are more prone to develop pancreatitis, which is a dreaded complication of hypertriglyceridemia. And very rarely supravalvular aortic stenosis we have seen, very rare disease. So always triglycerides better to keep it below 150. When
And cholesterol below
cholesterol
55.
below 100
Below 100.
LDL. And as you told, statins, this is one of the important drug. Myth is that if you take statins you are prone to develop diabetes. Most of the patients come to me that after taking, sir, lot of patients I have gone through the Google, sir, and lot of other doctors also told me that if I take cholesterol reducing medicines for longer time I will develop diabetes. Yes, see, thing is, if you take statins at a very high dose for a longer duration, there may be slightly increased risk of diabetes, slightly, but the benefit is around 99.9. The risk is 0.001%. So when statins are the very common group of medications which we prescribe for lowering the LDL cholesterol. Among them, we have something called as atorvastatin, rosuvastatin, pitavastatin. These drugs reduce your baseline cholesterol up to, depending upon the dose, from 10 to 40 or 80 mg, up to 25 to 35% of the baseline cholesterol can be reduced with it. So for the triglycerides, fenofibrates are the group of drugs which we give always most often for the bring down the triglycerides. And suppose if you are not able to bring down LDL cholesterol, there are familial hypercholesterolemia patients where LDL I have seen around 400, where in spite of we give statins for longer duration or higher dose, they are not. Now something called as PCSK9 inhibitors, this is the recent revolution in the lipid treatment. These are available as injectable forms. So you can give a monthly first injection at the time of diagnosis after an event, then 3 months, then 6 months. So we have seen LDL coming to as low as 20 after the injection. Only at present the drawback is little costlier. Cost effectiveness. Each injection may cost you around 90,000.
Okay. So now I want to come to Indian diet. Now that we have discussed about cholesterol and triglycerides, what are the changes you can make in your diet to reduce cholesterol and then reduce triglycerides?
Yes. See, most often our Indian diet is with a lot of spices, and ghee and butter is the main component of our Indian diet. So Indian diet, basically when you come, as you told, here comes the role of cooking oil. So general dictum, whenever someone asks me which oil you should use, I would say any oil at a lesser amount is safer. says they will ask, sir, can I use extra virgin oil, olive oil, virgin olive oil? Can I use safflower oil, sunflower oil? Yes. See, there is something called as smoking index for cooking oils. So generally, smoking index is nothing but you define whenever the oil is made to burn at the temperature where it starts burning out and releasing harmful substances is called smoking index. So for our Indian cooking, we need a little higher smoking index oils, because we have a habit of just frying, lot of boiling, or when you compare to Western where they have lot of simmering, or just they add like a sauce, whereas we have that thing to fry, boil the oil. So we use high cooking index oil. So for us, safer thing is uh, refined peanut oil can be used, sunflower, safflower oil, or avocado oil. All these are high smoking index oils which can be used for frying. And this olive oil and extra virgin olive oil can be used for toppings, or this, because they are rich with alpha linolenic acid and other good antioxidants also.
So, do you feel that we should use all types of oil? Maybe cook different vegetables in different type of oil so you get different nutrients, or do you feel that no, stick to only one oil?
See, this is generally a difficult question to answer, because definitely yes, if possible, one or two oils you can use for simmering and all. You can use if you are extra virgin olive oil, and for frying and all you can use other refined safflower or sunflower or coconut oil, peanut oil, that can be used.
Okay, so people say that nahi, the seed oils are much worse. Seed oils should not be used. Vegetable oil should be preferred, or rice bran oil is the best.
Yeah.
Is there anything like that in
See,
research?
yeah. See, canola or corn oil, all these are nothing but seed oils. They also have lot of omega-3 and omega-6 fatty acids. Yes, vegetable seed oils they stand one of the best one among the oils. After virgin olive oil or olive oil, then comes the seed oil, vegetable seed oil. Then we have this refined peanut oil, safflower and sunflower oil, especially refined.
Okay, so you're saying like if you want salad dressing or something in low heat, then olive oil can be used.
Yes.
But if it is high heat or deep frying, is it better to use safflower,
Safflower,
rice
or
bran oil?
rice bran oil can be used. Yes.
Okay. So, okay. And also, you think at least 2 or 3 different types of oil should be used and maybe rotate it?
Yeah, that can be done.
That will give
That
you all
can
the
be,
nutritional value.
Yes.
Okay. If I ask you, what are the best food items for heart health? To maintain heart, what are the best things that you can eat? Because, a lot of talk about flax seeds, chia seeds,
Yeah.
sunflower seeds, and
Yeah.
how they can improve
Yeah.
your good cholesterol. And so, little bit on that.
Yeah. Good foods for heart is first is colored vegetables and all colored fruits. As you know, as a dermatologist, to maintain glowing skin, we also want to maintain our glowing heart. So all colored fruits and vegetables are a must.
Because they are rich in
Yes.
antioxidants.
Yes, legumes also are good. Then you can use salmon fish, Markle's fish can be used. Then you can use flax seeds or chia seeds. Flax seeds contains lot of omega-3 and omega-6 fatty acids. These flax seeds can be powdered and you can use in the wheat flour when you are making a chapati or roti, so that you can use it. Then chia seeds contain lot of fiber, water retaining capacity is there, and also it also has omega-3 fatty acids. So those are the things. Salmon fish, and as I told earlier, they also have lot of omega fatty acids which are heart healthy. And fruits and vegetables and whole grains. Avoid processed food and especially dairy products. High butter. See, if you I forgot to mention one. Ghee has a high boiling point, smoking point, whereas butter doesn't have. So that is why ghee can be used for cooking more, frying, or whereas butter usually we use for dressing or doing sandwich or some other thing. Butter can be used. So anything dairy products, especially only skimmed after removing the cheese, all other things you can use dairy products. That also is okay for the heart. And nuts, walnut is and badam are very good for the health. They provide lot of omega-3 fatty acids only, especially walnut. That is good for the heart health. that can be used.
How many should be eaten? How many walnuts and how many almonds every day?
Yes. So generally you can have every day 3 to 4 badam and 1 or 2 walnut can be having whole.
Is there any difference between having it dry and soaking it? Any benefits of soaking almonds?
Generally I don't say no. I say no.
So any cardioprotective supplements? A lot of talk about fish oil supplement, omega-3 fatty acid supplements, or even coenzyme Q10.
Yeah.
So any impact of these supplements on heart health? Do you recommend them to your patients?
Yes. See, a lot of my patients also come and ask, sir, can I take fish oil or capsules, omega-3 fatty acids or coenzyme Q for my high triglycerides? Yes. These all can reduce your cholesterol level. They can reduce your triglyceride levels, and also they can reduce the hypertension. But these alone are not sufficient. One thing you have to remember is, in a patient, if you don't have any other risk factors, definitely yes, you can take. Along with that, lifestyle changes should be there. So these supplements should never be a replacement for lifestyle changes. This should be an add-on to your lifestyle changes. Then it will work better.
So lifestyle changes are number one.
Yes.
And then having a diet, a good diet. And then if you want to add in supplements, then. But
Yes.
you don't look at it as a replacement. You're doing
Yes.
everything else wrong, but then
Yeah.
you're taking supplements. It's not going to help.
Yes.
Now, so what is the impact of exercise on heart health? What type of exercise do you recommend to your patients? We talk about doing cardio, how much should the heart rate go up? How
Yes.
long should the exercise be
Yes.
for it to have a positive impact on the heart?
Yes. See, exercise generally, as per our cardiology perspective, we say minimum of 150 minutes a week.
Okay.
So 30 minutes a day, 5 days a week is sufficient. So when you come to the type of exercise, so generally aerobics, it should be a mixed one. Some people say that resistance training is not required, or some people are very pro for only aerobic. So generally it should be a mixed one. 3 days a week should be aerobic cardiac training. Another 2 days at least should be a resistant training. And because aerobic is mainly more important for your cardia, to increase your stamina, to keep yourself lean, and to reduce your fat. Resistant training, when you come to resistant training, it will increase your muscle strength, muscle mass, thereby improving insulin sensitivity. If your insulin sensitivity is improved, your diabetes risk will come down, and also your posture, stature also is better. It also reduces the risk of diabetes. And
Okay, so what heart rate should you reach when you are doing cardio exercises?
as I told, same thing. Your heart rate should never go beyond that calculated value. Suppose if you are a 40, 220 minus 40 is 180. So you keep your maximum heart rate should be within 180. Exercise should be the intensity of exercise should be such a way that your heart rate should never go up frequently more than 180.
Some people do have increased resting heart rate. Does that predispose them to develop heart diseases?
See, that is the baseline heart rate is indicative of your autonomic function. So if your baseline heart rate is more, it indicates that you have more sympathetic overactivity. Generally, if you see athletes have heart rate of 35, 40, and it is normal for them because of increased vagal activity. So lower the heart rate with exercise, longevity of your life is more. So you live longer.
So in people who have resting tachycardia, let's say,
Yeah.
Will exercises modify that?
Yes. If people who have more resting heart rate, if they start regularly exercising, their baseline heart rate start coming down.
What is the role of yoga, meditation, practicing mindfulness and its effect on the heart?
Definitely, yes. They have a very, very protective role. See, nowadays it is not only the physical health, it is also mental health also is very important. A lot of people, as I told, chronic stress has been a very important role in this generation for the cardiac disease. So work-life balance, family compatibility, and other issues are very common, which is leading to heart disease or hypertension or diabetes. So yoga or mindful, these things will keep your mind in peace. It will keep your mental health under control and delays the onset of all these things.
Now, when we're talking about this, I also want to talk about stress, the impact of stress on heart. Why do we always focus so much on de-stressing, on, like we said, yoga, mindfulness, meditation?
Correct.
What does stress do to the heart?
See, stress is a condition, as we know, that there is, whenever a person is stressed in the body, hormonal changes takes place. There are something called as good or bad hormones, or rush or stress hormones, especially adrenergic overdrive starts happening in when you are stressed. So these adrenergic are damageable to your body. So whenever this adrenergic hormone or rush happens during stress, they cause damage microscopically at the level of vessel. That will over a chronic period, the site of damage undergoes inflammation and initiates a plaque formation. Blockage happens, and that is how the over a chronic stress patient becomes prone to develop coronary artery disease. Or another scenario is whenever person has a block, suppose 40% or a 50% block, when you are exposed to chronic stress, that will lead to the rupture of the membrane over the tiles, and block rupture happens, and MI, you can have heart attack at that time.
Another major risk factor is smoking. So, just want to tell everybody how bad smoking is for the health, especially for the heart. So, what are the changes that can occur when a person smokes? What are the changes that occur in the blood vessel? And also, after smoking, how long will it take for it to all the changes to reverse? And does it ever reverse completely?
See, smoking increases the cardiovascular risk by 2 to 4 times. It is not only first hand smoke, second hand smoke, person who are exposed to smoking, that his friend or neighbors or somebody is smoking, and if you are exposed to smoke, the second hand smoke person also are at the risk of developing coronary artery disease. See, smoke contains lot of nicotine, tar and other chemicals. These chemicals initiate damage at the same as all the end result or the initiation process for any coronary artery disease is damage to the endothelium. So once this nicotine tar products damage the endothelium, they also accelerate atherosclerosis at that place, and these chemicals damage macrophages and other cells which act as scavengers at the level of microscopically at the level of adventitia or media. So they initially undergo transformation and they start forming a lipid core plaque. That is how they develop atherosclerosis and coronary artery disease with smoking.
And after stopping smoking, how long does it take for the cardiac function to come back to normal?
See, if you are smoking, even at 60, you please stop. Anytime it is beneficial. See, at 1 year of the after cessation, it comes to 50%. It may take 10 to 15 years for the person to be pre-smoking era.
Yeah, we used to read in our textbook that after 20 years of stopping smoking, your lung and heart function is almost similar to a non-smoker.
But I would like to stress that any age, even if you are stopping at 60, it's still beneficial. At 70, it is beneficial. At 20, it's more beneficial. I can say that.
Now, I want to talk about another agent that is very commonly consumed, which is alcohol. How does alcohol impact the heart? And is there any safe limit?
See, earlier there was previous studies used to say that moderate amount of alcohol is good for the heart or health. But now recent World Heart Federation 2022 data, there is no safe limit for alcohol. So
alcohol is actually now considered as a carcinogen.
Yes. Alcohol can initiate, it is a carcinogen like any other chemical initiating cancer. So there is no safe limit for alcohol. And alcohol generally, when you see this, it can affect basically in two ways. One is affecting the muscle, something called as alcoholic cardiomyopathy. If you have alcohol for a longer time, it can cause weakening of the heart muscle and leading to heart failure. That is called alcoholic cardiomyopathy. Second thing, something called as when you have a binge drink in some persons, they can develop arrhythmias, atrial fibrillation. It is called holiday heart syndrome. It is named because most often people drink binge on weekends on holiday days. That is the reason it is named as holiday heart syndrome. So when they have a binge drinking, suddenly their heart becomes irritable and they can develop atrial fibrillation, where their heart rate can go up to 300. 300. So these are two things which we see, and the third one is a long consumption can lead to coronary artery disease. So these three things are very common with alcohol.
Yeah, so that's why I think a lot of people feel that no, but he was absolutely healthy and he used to exercise, but just one episode of binge drinking, how can you have heart problem or suddenly collapse? It is because of arrhythmias.
Arrhythmias,
Arrhythmias do happen when you binge drink.
Yes.
Also, now we have enough data to refute that wine is not good for heart.
Correct.
It is an old study done, and now there is enough data to say that no amount of alcohol is safe, and the safe limit is 0. So if you're thinking in terms of longevity and for health, best to avoid alcohol completely.
Correct.
And so one controversial topic about COVID and heart health, a lot of people feel that COVID vaccines were causing increase in death, especially in young men. Any truth to that? What does research say? And what could be the reasons for increase in heart diseases post-COVID?
See, generally this is actually a controversial, yes. There was a dictum that a lot of people think that COVID vaccine has increased after COVID vaccination, a lot of young people are dying of heart attack. Yes. See, research has been done in 21,800 odd patients in Europe or somewhere I have read recently. They have done and shown that it is the COVID persons who has had COVID-19 infection. They had more than twofold increased risk of coronary artery disease for first 3 years after COVID-19 infection. But vaccine, it is controversial. There is no clear study. Recently, one ICMR study has done and has been told that there is no relation to COVID vaccine and coronary artery disease. But I would say in some different category of patients, along with that genetic predisposition or strong family history, or if they have unhealthy lifestyle, definitely may would have added or not, that still study has to say.
So it's mostly the COVID infection that is increasing the risk rather than the COVID vaccine.
Yes.
Because a lot of people are very panicky that, I took 3 doses of COVID vaccine, and people who did not take COVID vaccine or took only 1 dose feel that, oh no, they are safer. But it's not that. It's the infection that is
as per now reports which has been come out. And as we know that this COVID, during the COVID also, we would have seen a lot of people have been prescribing Aspirin for 3 to 6 months post-COVID infection. Yes, COVID virus has that tendency to increase thrombogenicity, clot formation. Maybe that may be the reason why patients are more prone for coronary artery thrombosis to happen or disease to happen in post-COVID.
And one more observation is that people feel that gym goers who go to the gym and make very heavy muscles, who are working out every single day and are extremely bulky, they look to us as healthy. They're maintaining their muscle mass, they're eating healthy, but they are more prone to develop heart diseases, or they are suddenly dying of heart disease. So what is the reason for that? And the role of anabolic steroids on heart?
See, this is very important. Lot of times, this has been a topic of interest. See, once we see in a lot of social media, television, that most important celebrities die during gym or die. See, it is you can't take it as only alone. Fit person alone can die only with the exercise. See, there are a lot of things which can contribute for the death. One is many times genetic predisposition, which they wouldn't have evaluated. See, many times we have channelopathies, one of the category of cardiac diseases, which may not have anything on outside if you visibly. Unless if you go in depth and genetic evaluation, those channelopathies can be diagnosed. So these channelopathies are precipitated while exercise, leading to arrhythmias and sudden death. Second thing is they would have anabolic steroids. These anabolic steroids, everybody wants to have a physical good appearance. They don't give much importance for the cardiovascular health. See, every gym trainer, if you see, they go to the mirror, they just want to look for the bulk of the muscle, physique. So, but they don't give much importance for the cardiac vascular health. These anabolic steroids, initially they try to to promote muscle erythropoiesis, they increase muscle generation, so helps in the muscle growth. The secondary effect is these anabolic steroids can increase the cardiac muscle growth, hypertrophy, and they are more prone to develop heart failure. They are more prone to develop arrhythmias. If you see, sudden cardiac deaths are common in these patients. Second thing is coronary artery disease is 3% higher in patients who take these supplements and gym goers. And heart failure, as I told, second. And they also have second thing, they don't have a proper sleep or dietary habits. They want to lose weight early, they want to lose fat, so they go for an unusual diets. I mean, for intermittent fasting or keto diet, or they go for lot of animal protein, only animal protein with fried, or so unusual diets. And severe dehydration. Severe dehydration is one thing which would have led to lot of sudden deaths in gym. So people doesn't give importance for hydration.
What is the impact of intermittent fasting on heart health?
See, intermittent fasting recent a few years back was one of the important topic of discussion, because intermittent fasting was helpful in especially uncontrolled diabetes, obese patients. So short term results were very good with intermittent fasting, where it will reduce your LDL cholesterol, it will reduce your insulin requirement, sugars will come under very good control. So these are all very short term, and it can indirectly affect heart. I mean, give a good feel for the heart initially. But long term studies have shown that 91% of them die of cardiovascular diseases with intermittent fasting if they have underlying heart diseases, especially if they are already had some heart attack, or if they had heart failure, and if they do intermittent fasting, these are the group of patients where they are going to die of heart diseases. So long term outcome is not good with intermittent fasting.
So very important. Also, can too much protein be bad for the heart?
Yes, protein, generally we say that there is no direct impact of protein on the heart, but most often higher protein intake has secondary maximum effect on the kidneys and gut. So more bloating, people experience lot of bloating, fullness, and also renal effects, because kidney has to filter fast, lot
So
of protein
can
burden.
that indirectly affect the
Yeah,
heart because
that
of the
can be a
kidneys?
secondary effect on the heart, but the direct effect is on the gut and the kidney.
Yeah, so we've covered all the risk factors in detail.
Yes.
Now I want to talk about, if a person has cardiovascular disease, what all minimally invasive procedures that can be done in order to save lives. So people are very worried about angiography, angioplasty. So I just want you to tell us about what those screening procedure and the treatment is, and the risk factors.
Yes. See, always whenever a person has an heart attack, always I would suggest, this is a very important message. You should always have 3 tablets in your hand. One is a aspirin, which we get as 300 Dispirin tablet 325 mg, clopidogrel 75 mg tablet 4, and atorvastatin of 40 mg. This is something called as emergency treatment. Whenever you suspect an heart attack or anything, should be given to the patient immediately. So once the patient has an heart attack, if you know diagnose, there are two things. There are places where immediate cardiologist is available. There are some district places or town places where cardiology facility is not available. Whenever you don't have cardiology facilities, first thing is there are some injections, clot dissolving injections, which we are available, anticoagulation, which can be given to the patient after ruling out the bleeding risk. The something called as streptokinase, tenecteplase, retiplase, these injections can be given immediately, because after an heart attack, always each minute is considered as very important. First hour is called as golden hour. The earlier you treat, the amount of cardiac muscle you save will be more. So that is the one. If you have accessibility, especially in the cities, immediately you have to take to the hospital where cath lab is available. First thing always in heart attack is angiogram. Angiogram is nothing, it is a minimally invasive procedure. It has evolved over years. If you see 10-15 years back, most of us used to do the angiogram through the leg, thigh, taking a prick at the level of thigh. Now 95 to 99% of the procedure we do through using the hand. So we take a small catheter needle, we put a needle, then access is obtained by using a small tube. Then we will use a catheters, and through the hand we'll pass through the hand up to the heart, aorta and heart. Then we engage the vessel and just we give the injection and we'll take. It is a small, minimally invasive procedure which will take hardly 10 minutes. Most often, average of 10 to 15 minutes is the one which is required for the angiogram. So once we identify any block, then see in the same setting if possible, especially in a heart attack, we use the same little bigger dimension catheter, engage, then we pass the wire, balloon, then we open up the block, then we put the medicated stent. So that is what we call it as angioplasty. So this is the gold standard treatment in any patient who has an heart attack. So this is minimally invasive, hardly requires half an hour to 1 hour. Depending on.
And what is the recovery after angioplasty?
See, generally after angioplasty, we say the patient to stay in an ICU for a day, 24 hours to observe for any, because first 24 hours there will be little bit increased risk of stent thrombosis depending upon the patient's clotting tendency, then medication related amount of thrombus burden. Then next day we'll be shifting to the ward. Then we will be discharging on the next day itself, hardly. Then patient can be in the rest for 2 to 3 days. That rest is nothing but he can do his own routine activities, need not go for a walk or lifting heavy weights. After a week he can start his routine activities as earlier before the procedure itself.
Even exercises can be started
Exercise generally after a week, start with a small walk, then gradually increase the intensity of the walk, brisk walk. Only thing what we suggest is don't lift the heavy weights immediately after the procedure. So after a week we try to ask them to not to lift more than 5 to 10 kgs weight, and while climbing the stairs just take a break after a floor, then reclimb the stairs.
So what are your thoughts on low dose aspirin? Should it be given to everybody? Who are the right candidates for aspirin? And what kind of laboratory tests they have to do, like PTINR, how often to check the levels? Yeah.
See, we would suggest no. Aspirin is not for everyone. So earlier there was a concept that aspirin, low dose aspirin in 40 or 50 plus people would have had reduced the risk of heart attack. Recent evidence says no. So we generally categorize whenever the patient or person comes to you as a risk of cardiac risk as categorized as low risk and high risk. Low risk is person doesn't have any history of cardiac issue or no risk factors for cardiac and age is less than 60 years with no aspirin. If the age is more than 60 or 65 years or some say up to 70, if person had previous history of any cardiac issue in the family, strong family history, diabetic, hypertensive, smoking, then they are considered as high risk and then you can initiate low dose of aspirin. Why we don't initiate in low risk is the benefit is lesser than the risk of bleeding with aspirin. So
if they are taking aspirin, they have to continue.
Yeah.
But if you have not been started, do you have to discuss with a cardiologist?
Yes. And then we can start. If necessary, we will start.
So this change has been made after certain studies which showed that
aspirin has not, rather than benefit, it is the risk of bleed was more, especially GI bleed. Because aspirin is a gastric irritant. So a lot of gastritis and GI bleed have been seen in the studies.
Okay. Let's say the plaque is detected on the artery. It is not a complete block, or let's slight plaque which is not blocking the flow. Can that plaque completely be reversed by lifestyle changes?
Definitely yes. That is why lifestyle changes are stressed upon. So it can reverse the mild plaque or plaque burden can come down with the good lifestyle changes.
So this is what I want people to know.
Yes.
Not get discouraged by knowing that there is a plaque or there is a block. There is always something that can be done.
This is the right point. Yes, patient should not be discouraged or patient should not get disappointed after they see some mild plaque 20%, 30% on CT-CAG. There is definitely a treatment. If with a good lifestyle, it is like a warning for you or motivation. You should take it as a motivation so that to prevent the future events, you can start with a good lifestyle. Definitely plaque burden will come down.
So what type of people should go for treadmill test?
Yeah. So a treadmill test is, generally treadmill test is nothing but looking for the heart function with the exercise. How heart respond to the exercise. Treadmill test is generally done in case of when a person is to assess his functional capacity. Second, to risk stratify whenever there is a chest pain. So many times what happens, 40 years patient comes to me, they say that he has a chest pain which is not clearly fitting into the cardiac or non-cardiac. So in those category of patients, treadmill can be done. Or person who has symptoms only on exertion. So person says that I am very comfortable at rest, but when I start walking for a half a kilometer or a kilometer, I start developing some uneasiness or shortness of breath. So these category of patients we can do treadmill. Or if a person is planned for any surgical procedure for the cardiac fitness or evaluation, we can subject him for the treadmill. And post MI risk stratification in chronic stable angina, where whether patient needs angiogram to be done or medicines are sufficient, that is another category of patients where we can do treadmill test.
Okay. Thank you so much, sir. This was very informative. Just before parting, 3 things you want everybody to know about heart health.
See, till now, as we know that the entire discussion stands on lifestyle changes. So having a good lifestyle, especially healthy food, regularly being active, managing stress, is these are the 3 things with good sleep. These 4 things will definitely reduce the risk of heart health and other diseases also.
Okay. Thank you so much, sir.
Thank you.
Thank you for watching the podcast. If you like such health related content, do follow us on our Instagram handle, Decoding Health with Dr. Aanchal, where I post such content daily. If you like skin related content, then follow me on Dr. Aanchal MD. Thank you for watching.